either a elevated troponin or BNP or a RV dysfunction on echo. If both are there, he becomes intermediate high. Then you monitor him, and if he sinks, then you lyse. But this is sacrosanct because many trials have come on this. I think Plitho, Medit, and all that stuff. You cannot lyse a pulmonary embolism who has normal pressures because you do more harm than good. Okay, and second is clot burden is not a criteria for lysis. RV dysfunction is not a criteria for lysis. So he will actually, if you had done the BNP and the troponin, then we could have said whether he is intermediate high and intermediate low. So the only treatment to give him is therapeutic anticoagulation. That's it. So I mean, I personally, yeah, but even if it's intermediate high, you will not thrombolyze unless he gets hypotensive, and that is also defined less than 90, more than 15 minutes without evidence of hypovolemia and other causes. See, it's not what I'm saying. There are certain things which are very sacrosanct, in no exam, especially MRChem or anywhere, you can pass in the world if you thrombolyze this patient.
Yes, sir.
Second is, yes, even I have lice with streptokinase, I think 96 or so it works very well. It works very well. And what you must know as an emergency physician is if a patient comes in cardiac arrest and you see a clot there and a RV dilated, then you should have some front loading regimen ready with reference.
Yes, sir.
So that.
So this an input. This was a case which I saw in the ER myself, and the team was already doing the ABCD. The point where it was interesting was it was a patient who was breathless with a clear chest. And one thing which Aditya has not mentioned, the patient also had a simultaneous SVT. So the focus of everyone went to the SVT treatment, ACLS pathway. In that, if you have a clear chest, when you have a clear chest, then I said, wait, something is wrong here. We need to rule out why. If you have a breathless patient with a clear chest, clinically think of a pulmonary embolism. And then the history he mentioned, we went looking for the pain in the leg. And this patient came with a very poor saturation. He was on NIV. And the entire discussion came, what Vivek sir has said is absolutely correct. It's very easy to manage the one who's crashing or the one who's a green patient. It is this intermediate risk. In the intermediate, the recommendation is to do intermediate low risk, intermediate high risk. In the intermediate high, you should do it through a multidisciplinary consensus and come to an evaluation. So luckily, because of our COVID experience, we have done this so often. RV-LV ratios, RV strain pattern, a rising troponin. There are in fact lovely Indian guidelines also available for management of an acute PE. Dr. Dalal, who is the senior cardiologist in Kokilaben, that Indian ICU group has released these guidelines. But it has to be by a multidisciplinary consensus. Decision to thrombolyze in this case was basis of the respiratory worsening and not on the hemodynamic part. Although we should have obviously used the Altiplase, which is recommended in this case, but because of the cost limitations, being a teaching hospital, in the scheme STK was used. Patient did show a response, but the patient did develop one of the other things which we don't share about thrombolysis is rethrombosis. So in fact, a re-interval scan actually paradoxically showed that there was a worsening and there was. So now how reliable is the report? So the thrombotic burden is there to confuse you. When the radiologist reports subsegmental, segmental, pattern, it all has to be put together.
The maximum false positives are subsegmental.
Yes.
If you look at literature,
Yes.
even the American College of
Yes.
Institute is very clear. So what I tell them here, the moment they write subsegmental, you reflect it is correct. Ignore it. Just look at the main.
MPA, the MPA and a saddle. So this patient, ultimately, what I believe is that the thrombolysis was a bridging intervention. It was the anticoagulation. And the patient did take time, but the patient took about 5 days to get off the HFNC and IV, and the patient did go home. And but again, P is something which, especially for those who have not worked during the COVID time, we must have done over 100 thrombolysis easily with streptokinase. Although we would have preferred Altiplase, there are regimens available. So STK still works. There is so B, but in the ER. At least giving that heparin bolus is the one thing which you can never say ki it did not strike me. Whether it's an acute coronary syndrome or an acute pulmonary embolism, giving an IV heparin, you are at an ER level, you are justified and very much indicated. You cannot not miss that. Be it for an ACS or be it for a P, if nothing else, give IV heparin, and while you get the ball rolling, involve your cardiologist, intensivist, radiologist. So, of course, this case goes into a next depth of analysis from a critical care point of view. But from an ER point of view, identification is one of the key parameters. And I think all of you will now go and read up about the intermediate PE.
So I think STK is good. There is nothing. See, most guidelines and literatures are driven by pharma companies from the Western world. The only difference between streptokinase and L-teplase is more clot specific. So if anyway if the patient's destiny is to bleed, he can bleed with L-teplase also, but he will bleed either in the head or in the stomach. With STK, the chances of bleed go up because it is not clot specific. So I think there is no harm, and we have to keep cost in mind because we come from a different economic background. Only thing is monitor. Just monitor the patient. Yes, and second is guidelines are guidelines since you're presented in a forum. But yes, if I had to go home at 8 p.m., I would have also said you start the lysis and I go. So, but monitor. So, and take the consent that he is borderline. Technically, we may not, but I think we'll be a little aggressive and monitor, and these are the chances of bleed. So, legally be safe.
Yes.
Thank you, sir.
Thank you, sir.
Anybody, any COVID resident who would want to share his COVID lysing story? I myself am one of them. Like sir said, we have at least lysed 100 in the last 3 years of COVID. And pulmonary embolism is quite personal for our department because one of our assistant professor, Dr. Mayank, he himself had pulmonary embolism. So sir would take any pulmonary embolism case very personally. So pulmonary embolism is one case where we would get the USG machine in 30 seconds here at MGM. So yeah, it's quite personal for us as well. Any questions? Yeah.
So you all have given only one bolus of 2.5 lakh units, and then have you? Okay, 1.5.
2.5 start, followed by 1 lakh unit per hour for the next 12 hours.
There are three regimens for a STK lysis. There is always a loading regimen, right? Following which there is a 12-hour infusion or a 24-hour infusion for PE, which is very unique to PE. And in a intermediate PE or a patient who is very critical, you have these high intermediate dose accelerated regimens. Now those are the ones you're not really sure. So probably in an ER, if the patient, like sir said, patient comes in cardiac arrest and you do not have the time to give a 12-hour infusion, obviously not, right? In those cases, you have the super accelerated regimen with a lower dose but over a shorter period of time. For example, Altiplase, the standard dose is 100 milligram over 2 hours. But an intermediate crash dose is 50 mg over 15 minutes. So those are the regimens. Of course, here we had to learn them because of the cost part. No, it was given the standard loading regimen followed by a 12-hour infusion, if I'm not mistaken. Per hour for 12 hours, and you can do it over 24 hours also. So in the ER, I would always suggest to go with a simple heparin. Now the LMWH is very good for a maintenance, and I believe that the LMWH the role starts outside the ER. Now if it's a very, very stable walking PE, then you can start with LMWH in the ER itself. In fact, in that case, if you're bold enough, diagnostic enough, you can initiate the patient directly on a NOAC. But that we will not do in a modern setting with the risk factor. But a heparin is short. Why am I saying heparin again? Short acting, reversible action. At that point in time, you don't know whether you still want to go for a catheter directed intervention. At that point in time, you're not really sure where this is headed. In fact, older literature used to say to start a heparin infusion for 24 hours. That I'm still not in favor of. I would rather say you give the heparin loading, while in the next 2 hours you're making a plan, next 2 to 4 hours you're buying time to decide what your final reperfusion plan is going to be. So the heparin gives you that 6-hour time to make a better plan. And although in a corporate, again, they would give an LMWH in the ER depending on the case, but I would still say heparin would be the safest, simplest, best choice. I think.
See, there is again nothing wrong with UFH, except that it's a cheap drug and pharma companies don't make money out of it. So you have to understand that in UFH, in an acute setting, you can give the bolus dose, you can run the infusion, you can titrate. it doesn't stop lysis if the patient crashes. It doesn't stop catheter-based lysis, and it doesn't stop a surgical embolectomy. Okay, low molecular weight heparins are more efficacious, but if you are given it, you are done for next 12 hours. Okay, and the third thing is the importance of low molecular weight heparin. It overscores unfractionated heparin after 3 to 4 days, because if patient is unlucky, then he gets heparin induced thrombocytopenia. So the chances of bleed, the chances of hit are more, and you don't need any lab test or monitoring for a low molecular weight heparin. But the moment you write unfractionated heparin, the ball is in your court. You have to sit, you have to monitor, and if you are running an infusion, then every 6 hours you have to run the PT nomogram and see that the patient remains. So the end point is patient should get therapeutic anticoagulation. That is what even the court looks at. Now, whether you use UFH or you use LMWH, and if you, and I think costing is a major issue across the world, and I think we should respect whatever, these are standard time tested drugs. Even most of the prescriptions I don't change for UFH, and I think the incidence of hit is rare. What I'll say is once in a blue moon you may see in a complicated case like that HELP and TTP, where anyway the platelets are down. So I think with UFH you take the responsibility that you will sit and monitor. With LMWH it's like done. You don't have to sit and monitor. And then in renal failure, now the second thing is these patients, you never know, diabetic hypertensive comes and he comes with a CTPA. Okay, you may get a creatinine of 0.3, but then you're pushing him in for a contrast, and after, if the RV becomes dysfunctional, then the urine output drops, and next day the creatinine jumps to 2. So then again unfractionated heparin is safe, and it can be reversed.
So I'll be very honest. IVC filter is something which is so heavily wrongly advocated in our country because of vested interests. There are very specific criteria for an IVC filter, very specific. Okay, so every PE case in the first line, there is no consideration at all. IVC filter should be the last thing on your mind. Unfortunately, it has been marketed and developed that you have to give a simultaneous call for, which is a horrible thing to do. There is not one guideline you can find anywhere in the world which will say that. There are
all the guidelines are very clear. There is no rule for IVCPS, except if you are in the ER and you have a patient say of malignancy who's been
Yeah.
had a DVT
Despite
before and who's been on NOACs, and before that he was on LMWH, and then who's failed and who's getting PEs again
recurrent
and again,
PE.
but has some quality of life and life
Yes.
left. Those are, because you know the first thing when you put a IVC filter is again you anticoagulate.
Yes.
You know, so if the patient has had a bleed, you cannot put a IVC filter. And IVC filter also has 3 months, 6 months. You can't put it for life.
Yes.
You know? So it is a double-edged thing. It can buy you some time. You know. So
So IVC filters they should be extremely rare. Okay, good. We have the audience wake up now. That's wonderful.
Yeah. Any questions? Then I will have one question for postgraduate. Yes. What is the rule of 3 for embolism? Except MGM. That they know. I know. Yes. Anyone? You can try. Because this was a thromboembolism. It's one of the favorite. If you see, this will be for anywhere.
This could be Viva questions. We are
Yeah,
letting our trade
not
secrets
only.
out.
All well score and everything. PRC, pulmonembolism, rule out criteria and everything. This is even radiological features in pulmonary thromboembolism itself is I slang. Nowadays it's medium answer questions. Yes, anyone? Otherwise I will say, yes, anyone wants to try? So it's a rule of 3 like air embolism, fat embolism and thromboembolism. 3 hours, 3 days and 3 weeks. Thank you.
Thank you so much, sir. Thank you so much, sir, for taking your time and presiding over the discussion. Next, we have a signature MGM brand ambassador case, the case that we see on a daily basis. It's polytrauma. To present this, I welcome Dr. Saurabh Basule, second year postgraduate of our department. I kindly request Dr. Aditi Singhani, head of the department, Associate Professor Family Medicine, to preside over the discussion to follow after the case presentation. I also invite Head of the Department of Emergency Medicine, Dr. Dattatri Busare, to preside over the discussion, to follow over the presentation.
Good afternoon, everyone. I'm going to present a polytrauma case. So patient YKL, 24-year-old male, presented to MGMIHS with alleged history of road traffic accident. Slip and fall from bike on 29th March 2024 at 5 p.m. He is sustaining injury to head, right lower limb and right third finger. He has 3 episodes of vomiting and loss of consciousness. On primary survey, the airway was threatened. Cervical collar applied and patient immediately got intubated in view of airway protection with 7.5 mm ET tube fixed at 22 centimeter lip marking and connected to ventilator on PRVC mode. On breathing, respiratory rate was 18 per minute with adequate depth with saturation of 98% on PRVC mode. Air entry bilaterally equal. Coming to circulation part, heart rate was 90 beats per minute, blood pressure was 130 or 90 millimeter of mercury. Distal pulses were present, peripheries were warm. We secured 2 wide IV cannulas and IV crystalloid started. While meantime, we noticed a swelling over right mid-shaft femur, so Thomas splint applied. Coming to disability part, GCS was on arrival E1, V1, M5, that is 7/15. Pupils bilaterally reacted to light, and RBS was 152 milligram per deciliter. On exposure, he has a lacerated wound over the right third distal phalange. We did some investigation in the ER. First, we did a chest X-ray, which was within normal limit. We did blood gas with a pH of 7.37. PCO2 was 32. Bicarb was 18.5 with slightly increasing lactate, that is 3.5, and hemoglobin on blood gas was 9.3. We did ECG, which was showing sinus tachycardia. The RBS was 152 milligram per deciliter. We did bedside fast, which was negative. Then we did X-ray, that is PBH and DL spine, which was also negative. Coming to ample history, patient has no known allergies, no medication history prior to that, no medical and surgical history in the past. His last meal was 11 a.m. in the morning. He presented to ER with allergy history of RTA, slip and fall from bike without wearing a helmet, not under any alcohol or drug influence, sustaining injury to head, right lower limb and right third finger. This is the chest X-ray and pelvic X-ray we did in the ER, which is normal. We did X-ray for thigh, that is right midshaft femur fracture. We give medication in the ER, that is injection tetanus, antibiotics, antiepileptics, analgesics, IV fluid, anti-ICP measures and antifibrinolytics. Then patient shifted to NCCT brain. So we did CT brain, which was suggestive of right-sided temporoparietal extradural hemorrhage. So surgery people has been called, and they advise to continue antiepileptics and anti-edema measures. Sedate and paralyze patient for 24 hours and repeat the CT brain after 12 hours as per their standard protocol. And later on, patient shifted to EMS ICU for further management. On the next day, the standard treatment continued as per neurosurgery plan. Repeat CT brain suggestive of increase in size of EDH. On next day, that is on day 2, at 9 a.m., patient was taken for decompressive craniotomy with evacuation of EDH. The course of event from day 2 to day 4. On day 2, the patient underwent decompressive craniotomy. At the evening, sedation break was given, and GCS improved to E2 VT M5 with pupils bilateral reacted to light. Supportive transfusions were given. As patient require prolonged IMV support, so we planned tracheostomy. On day 3, tracheostomy has been done, but had a perioperative cardiac arrest and Ross achieved within 8 minutes. Then post-cardiac bundles has been sent. On day 4 to day 7, patient got GCS improved and patient got agitated. So there is a fracture site. There is a swelling over the fracture site which was increasing gradually. On day 1, the hemoglobin level was 10.9. On day 2, it's brought to 7.8. On day 3, it's 6.8. So we did repeat fast scan, X-rays, and all the causes of bleeding has been ruled out. But it is found that the thigh is the fracture site is the source of bleeding, and as the swelling over the fracture site is gradually increasing and HB dropping. So we did UHG local part, and there is a collection in the right thigh. So immediately ortho reference has been given. Meanwhile, from day 1 to day 6, repeated blood transfusion has been given in order to maintain HB above 8. From day 4 to day 7, patient has seizure episode, hyponatremia, delirium, and mixed shock. For seizure, we did a repeat scan, CT brain, which is suggestive of no fresh event and bleeding. Also, neurology reference has been given. Neurology people advised to do EEG, but was not done due to unfeasibility. Then patient had hypoglycemic event also. So from neurology advice, we started second anti-epileptic drug. For hyponatremia, we did volume assessment and urinary sodium and samples were sent. So basically we are thinking about SIDH versus cerebral solve wasting. So it is found out to be hyponatremic hypovolemia. So gradual corrections were given. For delirium, the systemic evaluation has been done, and we avoided the systemic excess of the pharmacological drugs. Patient had mixed shock, that is hemorrhagic and septic shock. For hemorrhagic shock, we did multiple transfusion and source control has been done. For septic shock, patient has a fever spike. Patient's blood pressure went down to below MAP of 65. So we started vasopressus. We sent PCT, which was negative. So culture has been sent and continued on injections cefotaxime and metronidazole. Then blood gas suggestive of metabolic acidosis with CPK more than 3000, and patient has prerenal AKI, for which the supportive treatment has been given and volume correction has been done. On day 8 to day 14, for the sepsis part, fever spike continues but gradually decreasing. Patient has shock. We repeated the PCT, which came out to be positive. The lines, the catheters has been changed. There is a tracheal secretion. The TTK has been increased. Antibiotic escalated as per the cultures, and vasopressus and steroid has been added. We did a DIC picture, but came out to be negative. Then patient has developed left upper limb swelling between day 12 to day 14. So we did a DVT scan, and there is a thrombus in the left subclavian vein and cephalic vein. So we increased the heparin dose to BD. From day 15 to day 19, there is a resolution of sepsis. Pressure support tapered and stopped. Patient has febrile, and antibiotic de-escalate to tablet amoxicillin and doxycycline. From the ventilator point of view, there is a gradual reduction in FiO2. Weaning process has been started, and patient tolerated the TPS trials. On the day 19, patient has a minimal supportive transfusion, and sensorium improves. With sodium came out to be within normal range. No hypoglycemic events, no seizure episode. We did a CTPA to rule out pulmonary embolism, but came out to be negative. On day 19 to day 21, patient become hemodynamically stable on TPs, and gradually we kept on room air, which was maintaining. GCS improved to E4 VTM6. Patient moving all the 4 limbs, tolerating RT feeds as well. There is no surgical site infection at the post-operative site. Physiotherapy and rehab plans has been continued. Despite of day 21 of ICU admission, there is no bed sore. Then patient shifted to ward after 3 days of clearance and everything. This is the image of the patient on day 28. Patient got discharged with GCS of E4 VTM6 with tracheostomy in situ. So why this case? Basically, it's a polytrauma with severe traumatic brain injury. Multiple surgical intervention has been done. Patient has had a CPR of 8 minutes and secondary brain injury as well. Multiple hypotensive events and sepsis bouts are there. Multiple medical and surgical complications are there like sepsis, shock and everything. Prolonged ICU stay, that is 24 days with ventilatory period of 21 days. Patient is bedridden, but bed sore has been managed, which is a big challenge in MGM. Patient got discharged on day 28 with E4 VTM6. All teams working together make this episode possible. So there is a trauma death triad. Trimodal distribution is there. First is immediate, within hours, and then days or weeks. So immediately deaths occur within 50% cases due to brain, spine, aorta or heart injury. The patient were not able to reach the hospital as well. If they reach the hospital, there is a 30% chance of death due to lung, abdomen or lower limb injuries, and 20% chance of death due to ICU or IPD admissions because of sepsis or multi-organ failure. So there is a trial in the US suggesting the prognosis of the patient of moderate to severe traumatic brain injury. It shows 5 years plan. In that trial, there is a 22% death of the patients, 30% become well, 22% stayed same, and only 26% patient improved. So basically 57% are moderately or severely disabled, 55% do not have a job, 50% return to hospital at least once in their lifetime, 33% rely on others for help with everyday activities, 29% are not satisfied with life, 29% use illicit drugs or misuse alcohol, and 12% reside in nursing or other institutes. So take home point is polytrauma has a trimodal distribution of death. Management of ER is just a start of the journey. Multidisciplinary teamwork is the key. Daily rounds or notes is not the same as the patient care plan. Disease center care is not the same as the patient center quality of care. Nurses, physiotherapists and allied are equal team members in this whole management. Discussion among the colleagues and debate in interest of patient care must be encouraged. Shared goal setting and decision making is fundamental. A better system of care needs to be aspired towards ICU, IPD and post-discharge care. And most importantly, cost benefit and risk outcome are real world challenges in this area. Thank you.
And you can say it's a polytrauma. You can see that even 20% last, the patient has gone home on tracheostomy. He's a young guy with a small EDH, needed surgery after maybe like 12 hours. 12 hours he has undergone, and it is a multimodality. It is not only surgeons, physicians, but it is a complete case of emergency as well as ICU, because here this is a combined approach. Patient was there up to like maybe 3 weeks. Yes. So I think it is a team. What we say, what do you mean by team? Together everyone achieves miracle or more. Okay, so it is along with surgeons. We have got a very good neurosurgery team. So patient has gone home with this. Okay, so thank you, Saurav.
Even if the patients have improved, they have gone home, the treatment that they have to take at home and the mental status of the patient, because they are bed-ridden patients. Okay, so that has also to be taken care of for such TBI patients, I think so. Otherwise, they might just go into depression, though we have saved them, but there are other things that might come up for the relatives and for the patient.
Absolutely, ma'am.
So that thing also has to be managed well.
Actually, for such patients, post-discharge plan has to be planned.
Counselor, it is
counseling
better
has
to, yeah,
And also family counseling is also important,
yeah.
because
They
family
have to
suffers a lot.
work more harder.
Yeah.
It adds up to their work for the patient. So that is also required.
Yes, ma'am.
Thank you. Then one question for postgraduate. Can you name the Indian cricketer who died because of extradural hematoma? And in between, I request pronoting. So, to felicitate madam, Dr. Aditi Singhania. Yes, any answers from this side? I'll give
EDH.
one hint, R. Yeah, so sir, yeah, thank you sir. Sir, it's a Raman Lamba, okay? So who died? They are Australians also, but we must know first Indian. Yeah.
The new generation like me would like to answer the Australian cricketer.
The reason also we discuss this case here is that, remember, we are living in the era of modern interventions. So you will be seeing patients like this presenting to your ER. Somebody who's referred from a nursing home, somebody who's come with an in-situ tracheostomy tube. So with our systems of care getting better, this is now even going to be an ER problem. All these survivors, elderly patients, geriatric patients, trauma-based survivors, they are going to land up in your ER with a tracheostomy. And you can't say that what does this have to do with emergency medicine? The patient's route back into the hospital is going to be always back via your ER. And then you need to go back and understand, okay, what were the sequence of events? How do I understand what the risk stratification is? So emergency medicine, you cannot say this case is not mine. Each and every case de facto can be brought through your ER.
Hello, good afternoon. My question is, so patients who are coming severe traumatic brain injury or moderate traumatic brain injury, but on the examination or by the smell or from the history, we found that, okay, he is under alcohol influence. So monitoring his GCS, or what should be the threshold for this airway protection? So we should go ahead with airway protection, or just monitor is vitally stable.
What I feel is, see, once the patient is, as long as the patient's intoxicated, the patient was intoxicated, that itself is then GCS is out of question, right? You cannot assess. But since the patient's intoxicated, it is like a dangerous mechanism. Alleged history of assault under intoxication, alleged history of fall from height under intoxication itself is a dangerous mechanism.
You would not go ahead with direct intubation in an intoxicated patient. For airway management, you can go ahead and put an OPA if the patient is not phonating, because it is a reversible condition, so you would not directly plan intubation.
And one more, intoxicated patients, what I saw in the ER, they are more aggressive to manage. If you are putting cervical collar also, they will just throw it. So for them, a procedure sedation is added, or for the CT also. We are doing a CT, they will. So what is the, we can have the procedure sedation, which drugs we should use for the procedure
For
sedation?
alcohol per se, lorazepam is usually the drug of choice, but you have to see, which procedure you are going ahead for, and then accordingly you can decide.
I thought the question was intubation. I thought he was asking how to assess maybe the dangerous mechanism. As far as intubation is concerned, it's simple. Only 3 indications: airway protection, ventilation, oxygenation. One of them impaired, you irrespective of intoxicated or not. Like ma'am rightly mentioned, if the patient's intoxicated just for the reason that he's intoxicated, we would not tube. Although in a teaching college, we would even end up doing a tracheostomy. But yeah, in an ideal world, the right thing to do is not intubate. Anyone else? Sir, if you would want to share your thought on that. Anyone else? We'll move on to the next case. Next we have, please welcome Dr. Milan Rabadia, final year postgraduate of our department here at MGM, to present a case on post-traumatic meningitis in adults. I kindly request Dr. Sagar Sinha to preside over the discussion to follow after the presentation. I also request Dr. Khadija Jumkawala, Professor, Emergency Medicine at MGM Kamote, to preside over the discussion to follow our presentation.
Good afternoon, everyone. Case capsule. 20-year-old male patient was brought to our hospital near with complaints of seizure, high-grade fever, headache, and vomiting. Primary survey. Airway was pattern, breathing was respiratory at 20 per minute, SpO2 was 98% on room A. Circulation. BP was 120 by 80, heart rate was 110 beats per minute. Distal pulses were present. Peripheries were 1. Disability. GCS was E4 V5 M6. Bilateral pupils equally reactive to light. Random blood sugar was 146, and exposure was normothermic. Ample history. No any allergies. Patient was not on any medication. Past history of a road traffic accident, slip and fall from bike, injury sustained to height before 15 days. Personal history, bowel bladder sleep was normal, appetite were reduced, and no any addiction. Last meal 12 p.m. History of presenting illness, patient was apparently overnight before 1 day, then he had episode of high grade fever associated with vomiting and headache, and patient had taken treatment from local doctor and the symptom was not relieved. Then patient had a 3 episode of seizure at home and taken to our hospital for further punishment. Secondary survey. CVS S1 S2 were present, no murmur. Respiratory system air entry was bilateral equal. Per abdomen soft and non-tender. CNS. Patient was conscious oriented, following verbal commands. Pupils were bilateral equally reactive to light. Tone was patient had hypertonia, power was 5 by 5 in all limbs, no sensory movement, reflexes were 3+ in all limbs. Plantar, pubiscus reflexes on bilateral plantar, meningeal signs present, neck rigidity were present. ED adjuncts, chest X-ray net, ABG suggestive of metabolic plus lactic acidosis, ECG suggestive of sinus tachycardia, HGT 145, and provisional diagnosis of acute meningitis was made. Treatment given in the ER, injection ceftriaxone 2 gram, injection levetiracetam 2 gram, IV fluids 0.9% NS at 100 ml per hour, injection pantoprazole 40 mg, injection ondansetron 4 mg, and injection dexamethasone 4 mg. Investigation sent, CBC, CRP, electrolyte, serum creatinine, urea, fever profile, paired blood culture, and CT brain. Clinical progression, patient was shifted to ICU. Later patient gone into status epilepticus, developed a septic shock, antibiotic were escalated, tracheostomy were done in view of prolonged ventilation. Then further septic shock improved, GCS improved, and neurological status improves. Weaning started, and decannulation done, out of bed mobilization done, and patient was discharged with full power and full GCS. Discussion. Meningitis is defined as the inflammation of the meningeal linings, in particular arachnoid and pyometer and the subarachnoid space. Apart from hematogenous dissemination, there are other less common routes of CNS invasion, potentially leading to meningitis. For instance, microorganism may spread to meninges from contagious infected sites. Moreover, bacterial penetration into subarachnoid space might occur directly through a breach in the skull and adjacent soft tissues. In such circumstances, bacteria that physiologically colonize nasopharyngeal epithelium and sinus mucosa are mainly responsible for the infectious process. Antibiotic in bacterial meningitis. Antimicrobial treatment is the cornerstone of the therapeutic management of all pyogenic meningitis. Antibiotics should be started as early as possible, even before the isolation of causative microorganism through CSF culture, in order to minimize the risk of death and permanent sequel. Indeed, therapeutic delay is strongly associated with poor outcome. Before the specific pathogen is identified, empirical antibiotic treatment should be decided based on the patient age and known risk factor. common etiologies of bacterial meningitis and recommended empiric therapy. Infant younger than 1 month, empiric therapy is ampicillin plus cefotaxime. Alternative is ampicillin plus gentamicin. Children 1 to 23 months of age, empirical antibiotic vancomycin plus ceftriaxone. Alternative is meropenem plus vancomycin. Children and adult of 2 to 15 years of age, vancomycin plus ceftriaxone. Alternative is meropenem plus vancomycin. Adult older than 50 years of age with altered cellular immunity or alcoholism, ceftriaxone plus vancomycin plus ceftriaxone plus ampicillin. Alternative is meropenem plus vancomycin. Patient with basilar skull fracture or cochlear implant, vancomycin plus ceftriaxone, and alternative is meropenem plus vancomycin. Patient with penetrating trauma or post neurosurgery, antibiotic choice is cefepime plus vancomycin. Alternative is meropenem plus vancomycin. Patient with CSF shunt, empirical antibiotic choice is cefepime plus vancomycin. Antibiotic prophylaxis after traumatic brain injury. Another controversial issue in the therapeutic management of patient with meningitis is the need for antibiotic prophylaxis in subject with head trauma, especially those presenting with severe TBI. Indeed, despite the relatively low incidence of meningeal involvement among patients with recent trauma, when well-known risk factor for meningitis present such as basal skull fracture or persistent CSF leak can be identified, and chemoprophylaxis should be prudent choice as often used in clinical practice. Important risk factor for bacterial meningitis is acute or chronic otitis media, sinusitis, immunosuppression, splenectomy, alcoholism, pneumonia, diabetes mellitus, CSF leak, pneumonia, endocarditis, neurosurgical procedure, head injury involving neurosurgical device, cochlear implant, advanced age, malignancies, liver disease, unvaccinated to Haemophilus influenza type B, Neisseria meningitis, and Streptococcus pneumoniae. Take home message is the mortality of post-traumatic meningitis is greater than other type of meningitis, but it is preventable. Prophylactic antibiotic therapy is considered necessary for some head trauma patient with special indication. Thank you.
Interesting case. Normally, we always think meningitis is a sequelae of a pure medical disease. This was a rare situation where the patient came with a post-traumatic meningitis. And if you're aware of the BTF guidelines, they recommend even for an anti-epileptic which you give, it only has to be given for 8 days and it can be stopped. The question comes about antibiotics. Now, for everyone who's overprescribing antibiotics, they'll quote this case. See, if they had given antibiotic here, the meningitis would have happened. But again, the whole point is that all post-head injury may not get meningitis. If at all, there may be a specific consideration. Now, what are the obvious things in the ER? A CSF leak, a CSF otoriad is medically managed, any base of skull fracture. Because here imagine someone has survived the initial head trauma and 2 weeks later is back in your ER and he gets intubated, ventilated with septic shock, meningoencephalitis and has a 6-week ICU stay because of that with a status epilepticus. And then you go back and ask, when I sent him home from the ER, should I have just added that antibiotic in this particular case? So this is, the book on this is yet to be written in terms of what is the final answer, in which cases are very specific. But this was the case to highlight that even when we are sending home, I know we think antibiotic, we should send the patient home. But this is a true example that is the patient higher than normal risk? Then what to monitor, when to come back and seek urgent care to the ER. So a lot of responsibility comes to the ER. What I'm trying to say is that this is the way modern medicine is starting to evolve towards. That will be the only take home from. Any questions from the audience regarding this case? Ma'am, any inputs from your side?
Would like to, as madam has just retired on 28th of April, so from our department, we both would like to felicitate madam.
Big round of applause for madam completing her tenure as a medical college professor, giving her life and service to cause for the next generation of graduates. Ma'am, thank you so much on behalf of
would like to tell all the residents to do well and give the good results as we have given 10 years 100% results. So you have to sacrifice something. And since I am going, I don't want you to think that madam is gone. Who will scold me? Sir is there scolding. Be regular in studies. And I would miss you all everywhere.
Thank you, madam. Madam's presence was there for 4.5 years. So it was really a wonderful journey. Thank you, madam. Once again, on behalf of as a HOD and the Department of Emergency Medicine, always will be calling you as a ex. Like madam will be there for all, and she has accepted the invitation in spite of madam's health. Still, madam, you have come, madam. Yeah, thank you very much. Then one more question for postgraduate. As always, it's a Sagar's question. Where do you give double dose of like 2 gram of ceftriaxone? Sagar, I am right? 2 to 4, between 2 to 4 double dose. Which are the 3 conditions? Where do you give this? See, this may not be, I am not saying this is not related to this, but something, there could be some leak. See, as everyone knows, the basal skull fractures, either it could be anterior cranial fossa, posterior, middle. Anterior, they may present either with raccoonized traumatic rhinorrhea. Middle, they may present as a traumatic otorrhea or hemotympanum, or posterior, they may present as a battle sign, posterior cranial fossa. So, if even it could be a small leak, sometimes we say when giving spinal, andar gaya, but there is no free flow. There could be some injury for this patient because patient has presented within 2 weeks of this. That's why it is important. So, can anyone postgraduate? What are the 3 conditions where you may give the ceftriaxone between double dose like 2 to 4 grams? Yeah, double. One of them was this only. What are the other 2? Yes. Any upper GI? Yeah, SBP is different. Hope the residents have gained a bonus point here. These are trade secret questions of MGM, which we are letting it out. Next, we have Dr. Pranoti, second year postgraduate from our department, presenting a case on scorpion bite. I kindly request Dr. Tushayu Prasad to kindly preside the discussion to follow after the presentation. Also, Dr. Rahul Takshande, head IHBT, to preside the discussion to follow after the presentation. Over to you.
Good afternoon, everybody. My name is Dr. Pranoti. I am a second year resident in the Department of Emergency Medicine. Here before you, I am presenting a case of scorpion bite. A case scenario works as we received Mr. Ashok Singh, 26 years old male, who has presented to MGMIHS with alleged history of scorpion bite over a right forearm on 11th of April 24 around 6 p.m. while he was working outside. He has not taken any treatment on the same day and then was brought to MGMIHS the following day with the complaints of excessive sweating and breathlessness. Events that took place in the ER was airway was patent, breathing RR was 28 breaths per minute, adequate depth with SpO2 of 88% on room air, and air entry was bilaterally equal with basal crepitations. Circulation heart rate 174 beats per minute, BPU of 130 by 90 mm of mercury. Distal pulses were palpable, peripheries were warm, and 20 gauge IV cannula was secured. Disability, GCS was 15 by 15, that is E4, V5, M6, and pupils were bilaterally reactive to right 2 mm each, and the blood sugar levels were 123 mg per dl. Adjuncts we have ordered were metabolic profile of CBC, RFT electrolytes, TROP-T, CPK-MB and BNP. Blood gases which suggest a pH of 7.36, PCO2 of 35, bicarb of 20.6 and lactates of 1.1, and the hemoglobin over ABG was 14, which was probably suggestive of metabolic acidosis. Chest X-ray, which was ordered, suggested that the patient had bilateral pulmonary edema with cardiomegaly. ECG was taken, and that was suggestive of query atrial flutter with some STT changes and hyperacute T waves. And the HGT was 123 as mentioned earlier. Screening 2D echo was done, which suggested that the ejection fraction was less than 50%. Query anterior wall hypokinesia, and the IVC was more than 50% collapsing. Lung ultrasound was done in the ER, which suggested B lines, which was present in all the lung fields, suggestive of pulmonary edema. Ample history was taken. Allergies, no known allergies. Medications, not on any medications. No medical or surgical history in the past. Last meal in the night at 9 p.m. Patient presented to MGMIHS with alleged history of scorpion bite over right forearm around 6 p.m. The day before, he has taken no treatment, and he presented with excessive sweating and breathlessness on the next day. ABG was done, which was suggestive of metabolic acidosis. Chest X-ray was suggestive of bilateral pulmonary edema with cardiomegaly, which can be seen over the X-ray on the right side. ECG was done, which was suggestive of heart rate of 174, and flutter waves were seen. So we have made it as a atrial flutter with some STT changes and hyperacute T waves. Medications which were given in the ER, we have injected anti-scorpion venom, 3 mg in D5 over 30 minutes. Injection hydrocortisone 100 mg, injection Lasix 20 mg, injection heparin 5000 units, Evil 2 cc, tablet Prazosin 2.5 mg per orally was given to the patient, tablet Ecosprin 300 mg, clopidogrel 300 mg, and atorvastatin 80 mg was given. After this, while disposing the patient for further management, we have taken one ECG, which wherein the heart rate was has come down to 97 beats per minute, and then the plan of care was decided for the patient. Cardiology reference was given in view of findings over the screening 2D echo. He is advised for NIV or HFNC, repeat ECG after 2 hours, and the patient was then shifted for ICU for further management. In EMS ICU, day 1 vitals noted, heart rate was 88 beats per minute. The tachycardia was resolved. BP was 140 by 80, RR was 26, and SpO2 was 96 on 8 liters oxygen. In respiratory system, bilateral air entry was present, and also the bilateral crepitations were present. Blood gas was still suggestive of metabolic acidosis. Chest X-ray was ordered, which was again suggestive of bilateral mild to moderate pulmonary edema with mild cardiomegaly. On examination, there were no local inflammatory signs. Labs which came out told that the troponin was 38.9 nanogram per dl, and CPK-MB was 18 units per liter. And advice given was taper oxygen and standby HFNC or NIV, repeat cardiac enzymes, SOS inotropic support if patient develops hypotension, repeat 12-lead ECG, and potassium supplementation for supportive care. Treatment which was given in ICU, injection ceftriaxone 1 gram, hydrocort 100 mg, which was tapered and stopped later. UFH was continued, Lasix, Ecosprin, and all the statins with tablet Prazosin 2.5 mg only when the BP is more than 130 by 80. On day 2, vitals were noted, and the pulse rate was 84 beats per minute, RR of 20, BP of 140 by 90, and SpO2 was 96 on room air. Now the on respiratory system examination, the air entry was present and the creps were resolved on day 2 of ICU stay. Blood gas, the acidosis was resolved. Chest X-ray was clear, that means the pulmonary edema which was present has been resolved. In labs, we can see that CPK-MB and TROP-T remains still the same. Cardiology review was done, and 2D echo reviewed by cardiology, which suggested no RWMA, that is regional wall motion abnormality was not there. Mildly reduced EF 45 to 50%. Query scorpion sting myocarditis. IVC was still collapsing, and cardiology advised to hold statins. Advice given was to increase hydration as the crepitations and the overload was has come down. Clinically, the patient was better with stable hemodynamics. There was no acidosis on blood gases. Urine output was more than 0.5 ml per kg per hour, and the patient was planned to shift out of ICU. On day 3, the patient was shifted to male medicine ward and continued for the same treatment. On day 4, patient was discharged with tablet prazosin 2.5 mg BD for 3 days and was advised to follow up in cardiology and medicine OPD after 3 days. A discussion, scorpion envenomation is an occupational hazard. Mainly it is seen in farmers, laborers, villagers and hunters. The large families of the scorpion belongs to family Buthidae, and the most notorious ones, the most venomous ones are the Buthus and the Parabuthus. Scorpion venom, when the scorpion bite is there and the venom is deposited in the skin, it is deposited deep to the subcutaneous tissue, and almost complete absorption takes at least 7 to 8 hours. The main molecular targets of this neurotoxin are the voltage-gated sodium channels and the potassium channels, including calcium-activated potassium channels. And mainly the neurotoxins act on the excitable cells of nerves and muscles. Clinical manifestations, generally the envenomation depends upon the species of scorpion, the lethality and the dose of the venom that is injected. Clinically, we call the term as autonomic storm, which is evoked due to venomous envenomation, which is characterized by initial phase of parasympathetic activation, later by the sympathetic arousal. Initially, we have the patient has vomiting, profuse sweating, ropey salivation, bradycardia, priapism in males and hypotension. Later on, there is a sympathetic activity which is prolonged, and the patient may present as cold extremities, hypertension, tachycardia, pulmonary edema and shock. There are three classes based on this, and class 1 wherein there is just local manifestation, class 2 wherein there is systemic involvement, class 3 wherein there are multiple organs involved, like cardiogenic failure if it comes to heart, hypotension, ventricular arrhythmias, bradycardia, or it can be as worst as cardiovascular collapse. In respiratory, patient can develop cyanosis, dyspnea, pulmonary edema, or in CNS system, it can also even lead to coma and paralysis. Local manifestations, a patient can have severe excruciating radiating pain at the sting site, which is called as TAP sign, which is defined as when the patient is stabbed on the same side wherein the sting has bitten, there is quick withdrawal from the site, and this is very diagnostic of the scorpion sting sign. Second, it can also manifest in edema and inflammation, for which digital block can be given in the ER with administration of 2 ml of lignocaine without adrenaline, or cold packs and oral NSAIDs for symptomatic relief can be advised. Systemic manifestations, like first it will have a parasympathetic manifestations in the form of vomiting, profuse sweating, salivation, priapism, cold extremities. Later on can develop to mydriasis, hypertension, tachycardia, hypotension and pulmonary edema. Hemodynamics, we generally go for echocardiography, ECG and chest X-ray. Echo reveals poor global myocardial contractility with low ejection fraction, decreased left ventricular performance, trivial MR with abnormal diastolic filling, and hypokinetic left ventricles. ECG might show tented T waves, which are referred to as Ashoka tree appearance, and it suggests of acute injury, while tent-shaped looking Christmas tree indicates that the patient is recovering. Chest X-ray is suggestive of bat wing appearance. That means that means the victim has developed a cardiogenic pulmonary edema, and these are the chest X-rays, which the upper 3 chest X-rays are showing the developing pulmonary edema, whereas the lower ones are post-oral prazosin dose, wherein you can see that the last X-ray on the left side, the pulmonary edema has resolved completely after 2 days of oral prazosin. Management, anti-scorpion venom without skin test has to be given to the victim in the ED as early as possible through venous route. And prazosin, as we know, is an alpha blocker and acts as a antidote for venom. Scorpion sting is generally presented in 5 stages. In first 4 hours, there are parasympathetic drive. So patient can be treated with that is anti-scorpion venom and prazosin, and the patient is found to recover. In the second stage, wherein the victim presents after 4 to 6 hours of envenomation, and wherein the sympathetic system has taken over now, and the patient will present with symptoms like hypertension, tachycardia, cold extremities. In this patients also, anti-scorpion venom and prazosin are helpful, and the patient can get recovered. In third stage, wherein the multiple system gets involved, and the patient now can need inotrop like dobutamine and an IV support, or the patient might need a mechanical ventilation for recovery. In the fourth stage, wherein the patient is found to have developed massive pulmonary edema, then the patient along with anti-scorpion venom might need sodium nitroprusside or NTG, that is nitroglycerin, because and also might need an IV and a mechanical ventilator. NTG being a venodilator will relax the coronaries, and it might also provide a symptomatic and might even reduce the fatality in the victims. The stage 5, wherein it is more than 12 hours, the patient presents in pulmonary edema, hypotension, warm extremities, which is generally called as a warm shock, and the patient now needs a dobutamine for recovery. To conclude, early hospitalization and administration of accurate dose of anti-scorpion venom and prazosin, and closely monitoring the victims in intensive care unit will save many lamented lives. Thank you.
Kindly request Dr. Kushayu Prasad to share his ideas on the topic.
Thank you so much. Very well presented case, and I would say a very interesting case. Had a wavy storm. Now, first of all, most of us, we work in urban EDs, so we don't get a lot of animal bites, specifically scorpion bites. Now, the challenge in facing a case like a scorpion bite is, first of all, establishing whether it is a bite and there has been an envenomation. So how did you come to the conclusion that there has been a scorpion bite?
So first of all, the history was suggestive that he had a scorpion bite because the victim has witnessed the scorpion, and he has also got a phone. He has also got a photo. So and that was very easy for us to diagnose it. And he has typically presented with the symptoms of, and he also had a sting marks over the right forearm. And the sting sign, the type sign which I have mentioned, I have actually performed it on the patient and came to positive. And a third thing was that we knew that the patient came with breathlessness, so might have pulmonary edema, which is a deadly complication of scorpion sting.
Right, so you were sure it was a scorpion bite. Why? Because unlike snake, where to establish envenomation, you can do the whole blood coagulation test. Secondly, for scorpion bites, there is no specific test to establish, as a point of care diagnostic to come to the conclusion. Third thing is, as you very well explained, so basically scorpion bites will not cause systemic toxicity until and unless the dosage has been, pretty excessive. And I think, in literature, less than 10% is what they will have systemic envenomation. And your case is one of the less than 10% category.
Yes,
as you rightly said, there is excessive sodium channel reactivation and excessive catecholamine surge that gives us that sympathomimetic response. So like any toxicology case, in medicine we have syndromic approach. In toxicology you have the toxidrome approach. So I think your case had a lot of catecholamine surge, sympathomimetic surge that led to rate-related heart failure, pulmonary edema, and then mostly I think it is all about managing it well in the ICU, daily monitoring and giving supportive treatment. Which category did the patient fall in as per your last slide
my
classification?
patient fall in third category. Yeah, he fall in the third category, wherein he was the symptoms resolved on giving anti-scorpion venom and prazosin. We had a plan to put the patient on NIV, but then the crepitations were resolved and there was no indication of NIV. The patient's lab reports improved gradually. So though the HFNC and NIV was on standby, and patient didn't develop hypotensive episode during ICU stay. So we didn't need any inotropic support also.
Yes, I think NIV diuretic and
Yes, sir.
your antihypertensives help. One more precaution is while giving antivenom, anaphylaxis is a really well recognized complication. So whenever we are giving any antivenom, please be around and be ready with your adrenaline just in case if the patient has anaphylaxis. Thank you. Well done. Thank you.
Thank you, sir.
Very well presented case. I would just like to know how many cases you are getting in this area. Because I come from JJ Hospital where we haven't heard of so many cases.
Sir, once in a month.
Once in a month. And you have said this patient present, did he present with the pulmonary edema?
Yes, sir. The initial chest X-ray showed pulmonary.
Besides prazosin, do you have any other drug?
Yes, sir. In more devastated cases, amiodarone is suggested. But then our patient didn't need that. The symptoms were subsided on giving prazosin and anti-scorpion venom.
Okay, but because in the entire discussion, it was a very well presented case. But the only thing that I could pick up prazosin. Besides, I myself have been the victim of this scorpion bite. In those days, we had in our village a homeopath. So I was taken by my elder brother. I did not know what he did. He just instilled few drops. What drug it was, I don't know. But after half an hour, I got very well. I could walk, I could run. So those were the days. Do you know any person who has been working in this field? Can you name me the person? He's a very famous.
He's come to MGM 4 times also. Yes, he stays less than 40 minutes.
Dr. Bhaviskar. Thank you so much. Thank you.
Sir.
I request, yes sir, thank you sir. I request Shruti Menon. Shruti is there? Yes. To felicitate sir. And next, ready for the next case.
Thank you so much, sir. Thank you so much for sharing your ideas on the topic. Like sir said, very rare, less than 10%, but surprisingly here at MGM, we do get cases like once in a month. Probably the complicated ones quite rare, but scorpion bites, yeah, we do get. So the last case for the day, then we break to lunch. I welcome Dr. Manali Deshmukh, first year postgraduate from our department, to present a case on organophosphorus poisoning.
Good afternoon, everyone.
I kindly request Dr. Kunjalakshmi, Senior Resident, Department of Emergency Medicine, to preside the discussion to follow after the presentation. I also request Dr. Nakul Ram, Senior Resident, Department of Emergency Medicine, to preside the discussion to follow after the presentation.
Good afternoon, everyone. So my case is about a pediatric case of organophosphorus poisoning. Okay, so this was a rare case because the female who came to the ED was 16 years old. A 16-year-old female was brought to MGMER, referred from local hospital, Karzat, with alleged history of 4-8 powder consumption 6 hours back. Patient presented with decreased responsiveness, 1 to 2 episodes of vomiting, frothing from mouth, excessive salivation, and loose stools. The course in ER. So the airway was threatened. There was a lot of pooling of secretions. The intervention that was done was suctioning. Propped up position, 30 degree was given. Patient was immediately intubated and mechanically ventilated for airway protection. Breathing. The RR was 22 breaths per minute. Bilaterally symmetrical chest rise. Air entry decreased bilaterally. Bilateral crepitations present. Mechanically ventilated and on PAC mode. PIP of 12, PEEP of 5, FiO 200. Chest X-ray and ABG was ordered. Circulation. Heart rate of 84 per minute. BP was maintained at 110 by 70 mmHg. Peripheries were warm. CRT less than 3 seconds. All peripheral pulses present. Large bore IV cannula inserted. Samples collected and IV fluids 0.9% NS started. Disability. Initially on arrival, her GCS was E2V2M4, and after tubing it was E1VTM1, sedated and paralyzed. Pupils were pinpoint, bilaterally reacting to light, and RBS of 115 mg per day. Decontamination and exposure. There was pungent smell noted. Contamination clothing removed and body wash given with soap and water. White colored pungent smelling fluid was aspirated from Lyle's tube. ER adjuncts. ABG done was suggestive of pH 7.37, PaCO2 35 mmHg, PaO2 91 mmHg, bicarb of 21.4, and lactate of 0.9. This was the X-ray that was done, and Foley's and Ryle's tube inserted. ECG was suggestive of sinus rhythm. Ample history. There's no history of any allergy, no history of any medications or any previous hospitalization, no significant past medical or surgical history. The last meal was taken at 9 a.m. in the morning, and LMP was 10th of April 2024. History of present illness. At 11 a.m. in the morning, patient was apparently all right 6 hours back when she consumed unknown quantity of 4,8 compound. 10 minutes later, the child was fed cow dung water and made to vomit. Child was then fed one banana, post which she had 1 to 2 episodes of vomiting with food as content. At 3 p.m., child was found drowsy with frothing from mouth by her brother in the kitchen. So at 3:30, patient was rushed to a local hospital where she was made to have 1 liter of potassium permanganate, post which a stomach wash was given and the child was referred to MGMIHS ER in view of deteriorating sensorium around 6 p.m. There was no history of LOC or tongue bite. General examination, GC was poor, GCS of E2V2M4. Temperature, she was febrile. Pulse rate of 76 per minute, saturation of 90% on room air, and BP of 110/70, RR 24 per minute, RBS of 115 mg per TL. No pallor, icterus, clubbing, cyanosis, lymphadenopathy, or edema. Systemic examination, CVS S1 S2 heard, CNS E4V1M4, pinpoint pupils, fasciculations were present, air entry bilaterally present, and bronchoria was present. Per abdo soft, no GTR. Diagnosis. 16-year-old female with allergy history of organophosphorus compound consumption, that is 4,8, with signs of acute intoxication. Investigations that were sent in the ED were CBC, electrolytes, and serum cholinesterase. Treatment given in the ER, injection atropine 0.05 mg per kg bolus. Every 5 minutes the dose was doubled. It was given 3 times and the signs of atropinization were achieved. That is clear chest, systolic BP more than 80 and heart rate more than 80. Followed by continuous infusion of 0.02 mg per kg per hour. That is 10 to 20% of initial dose to achieve atropinization. Injection pralidoxim 30 mg per kg over 5 minutes was given, followed by 8 mg per kg per hour of infusion for 24 hours. Injection PAN 40 mg, injection MSET 40 mg, and IV fluid NS was started. The lab investigations like serum electrolytes were sent and potassium was low, so for which KCl was given. Cholinesterase levels were low, that is 375 units per liter. Disposition. Pediatric reference was done, patient was admitted in pediatric ICU. Course in PICU. Ongoing infusion of atropine and pralidoxime. Resolution of bronchoria. Neurological status, GCS improved to E4-VTM6. That's why weaning of trials were given and the patient was extubated in PICU after 24 hours. Patient was then shifted to ward 2 days later. Outcome and follow-up. Cholinergic symptoms resolved. Patient counseled and asked to follow up in OPD. Patient discharged on 27th, 4/24 after 6 days of hospital stay. Discussion. This was a case of organophosphorus compound poisoning with acute cholinergic crisis. The principles of care are like early recognition, decontamination, and administration of antimuscarinic, that is atropine, and the antidote, that is oxime, pralidoxime. Thank you.
Thank you. Kunju has done a thesis, a research on cholinesterase levels, so I think she's the right person who can comment on OP poisoning.
Manali, good presentation. So if you look at the presentation here, some things that I were disturbing are the facts that have happened outside of this hospital. Like before coming to the hospital, what all was given to the patient, and also the role of decontamination. One thing that I think toxicology, when we come across, one thing that we have to focus on is decontamination before you start your obviously airway management. Other than that, I would also say that lavage, again, yeah, I don't understand why we go ahead with lavage. There are very few indications for us to do that, and if you're doing that, again, the presentation should be within 1 hour only for select poisons.
Ma'am, lavage was done in the outside hospital.
Yeah, again, I'm just speaking of the things that we've seen here that are, and then another thing that we'd have to talk about is sending markers. And also, so if we are talking about markers, again, we have two types of markers. My thesis was on RBC cholinesterase, but again, in our resource limited conditions, it would be better to go ahead with serum cholinesterase, where in which you can look at the levels of it getting depleted in an organophosphate poisoning. So basic thing that you have to look at. So now if we have a patient who's coming with OP poisoning, look for signs of OP poisoning. If you're suspecting OP poisoning, you need to know what the toxidrome is. So with all toxicology cases, you need to know what toxidrome are you going to look for. So look at your normal sludge dumbbells, all the things that you have been reading. Nice presentation.
Nice presentation, Manali. One of the habits that has been followed here is we always give atropine till the resolution of fasciculations and pupils also, which is never needed. As she has already mentioned, heart rate more than 80, BP more than 8, systolic BP more than 80 millimeters of mercury, and absence of bronchorrhea. At that point of time itself, you should stop atropinization and give 20% infusion of the same. It was a habit that was died hard, but at least for now, in the progress of dying, but at least now we are trying to abolish the same and continue as per what they have mentioned.
And especially, I think this would answer your question of intubation as well. How many of you have read Rosens? That's the Bible of emergency medicine for the residents. Rosens. So anybody? Rosens? Rosens, yeah? So, if you, it is a line, it is a line from Rosens under intubation indications. Apart from these three indications, airway protection, oxygenation, and ventilation, they've specifically added a line for toxicology, especially for this OP poisoning and BZD, benzodiazepine poisoning. So if you're anticipating an immediate clinical improvement, then you could wait. This is Rosens, not me. This is Rosens. It is a line. So if you could achieve airway protection with some probably an OPA, NPA, supraglottic or something, you could avoid intubation. Even if airway is not protected, if you are anticipating an immediate clinical improvement, like if you have a magical antidote. So specifically in toxicology is a place where we could wait. Again, intubation is intubation. It's subjective. It's what you are going through at that moment of time. Anybody could put a tube out of panic and all of that. Yeah. Anything else? Any doubts? OP poisoning.
So if you were to look at the acetylcholinesterase, the regeneration of acetylcholinesterase is much accelerated as compared to that of RBC cholinesterase. So the regeneration is about 120 days when it comes to RBC cholinesterase and about 7 days with serum acetylcholinesterase. So if you're looking at the severity or prognosis, studies have shown that RBC cholinesterase is a much better marker as compared to that of serum cholinesterase. Serum cholinesterase can say that, okay, we have a patient who probably has organophosphorus compound poisoning. I mean, it is more of a diagnostic marker rather than it would just say that it is there has been an exposure to organophosphorus poisoning rather than the severity. Prognostication is, even Baviskar sir has actually made a paper on the same with RBC cholinesterase. So that is what it is. So
That's why it is called as a true cholinesterase, if you see. And those who are exposed to all those workers, that's why it is their chronic exposure. Always it is a true RBC cholinesterase. That's why the topic. We needed more study for that, but it's a really pseudo is serum and true is a RBC cholinesterase. Okay. Any questions? Then I request this thing, Rishi, yes, to felicitate Dr. Nakul. Varun, you also come. You are yes, come here. Yeah, photo. I request Manali to felicitate Dr. Kunju, SR in EM. Yeah. We request Mandar to felicitate Varun. Yeah. And Saurabh to sit. And last, Dr. Sagar. I request Varun. Yes. Yeah. Because see, without it's a teamwork, and three of us. Yes, yes. Because he has taken over as a distinct coordinator as well as this. Yes. Thank you, Varun. And we are there all the time. There is no problem of that. At the same time, I take this opportunity because we have felicited all our IT team. Yeah, College of Physicians and Surgeons, Vithoba Chauhan. We have held uninterruptedly. He is there since yesterday afternoon. I think, yes, thank you. I request Sagar. Yes, come. Yeah, दोगे या दोगे या. So both will. Because the IT team who is working since yesterday afternoon, in spite of so many hurdles, then we had likely to know that we have got a even transmission of on YouTube channel.
Yeah, this is live on YouTube right now.
Already we have sent. You may not be aware. It was just immediately 2 minutes after.
Yeah.
Yeah. So thank you, and all at the end I request. Thank you.
So just before I propose a vote of thanks quickly, two things. One is that please leave your registration for your feedback forms your way out on the registration desk. 2, lunch is already been served next door, so please have your lunch. 3, very importantly, I'll request some of our emergency medicine colleagues who have come from the other departments. A show of hands, please. Yes. Yeah. Oh. So what I'll do is I'll request after the lunch, I will request all the emergency. Ma'am, please come. Because apologies today that we were. Ma'am, will you introduce yourself? Sorry, we've
myself, Dr. Vaishali Mohd. I am head of the Department of Emergency Medicine. Last year only we started with the 5 seats of emergency medicine, and I am also learning. And it was a very nice program today, and all the cases where we used to do the clinical meds in our own way, but it is only a simple one because I am an anesthetist here. I am anesthetist and critical care. So I am also learning emergency medicine. And we have other new branches, geriatric medicine and all those here. So all of us are doing such kind of meets and discussing the cases, but this was really a very good year. Thank you so much for it. And no, it's okay. Yeah.
I must thank him.
Yeah.
He sent the madam.
Yeah.
So the third announcement would be, I'll request that all the emergency medicine, our colleagues from the other institutes have come. After lunch, if you could join us in the ER and to our seminar room for a closed room discussion. So those who are wishing to stay back, just to network a little bit more. So those are the three announcements. Yes, so formal vote of thanks on behalf of the entire MGM Department of Emergency Medicine, Professor and HOD Dr. Busare sir, Professor Dr. Jhumkawala madam, on behalf of all the team of the SRs and JRs, firstly I would like to very much thank all the delegates who have made it possible today. It is an emergency medicine clinical academic meet. It is not complete without actually having the participants. Secondly, we are grateful to the institute for allowing us and making all of this possible for us. Special thanks, I would say, to the coordinator for today, Dr. Varun, who is the coordinator and who has made all this possible. And I would request all of you a big round of applause for our 10 presenters today. So a big round of applause for them. Yeah, one GR1, yeah. And all our moderators, faculties, in-house, external who have come. We hope that you've had a pleasant experience. We hope that this is the start of something a lot more to come. And sir has already acknowledged all our AV team members. We have our housekeeping. We have the lunch being arranged. We have our physician assistants who are helping out. So on behalf of the department, we thank you once again. We are very glad to have you here and we look forward to doing these activities more and more again. Thank you so much. Please join us for lunch.
वो उसका रहेगा, ये उसका है। नहीं सर, ये आपका है। ये रेड मेरा है। रेड आपका है ना? आमचा है सर। अरे एक में रेड, वो इसने अपने लिए ना वो चाहिए वो